which confirmed factual myth. So we gave palliative radiation therapy, 30 grain 10 fraction, lumbar and dorsal in up to August 2020. In August 2020, November 2020, reviewed CMC Kolkata again and switched to tamoxifen 20 milligram and continued up to May 2021. In June 2021, repeat PET scan done at Bangladesh and progressive disease in hepatic cells with multiple bone mets with failure of previous treatment bony sites. Now she is planned to again EBRT due to significant pain in the right pelvis and cervical spine and sternum. This is her recent PET scan. She had this is the hepatic lesions in multiple regions, multiple lobes. And this is the significant new lesion in the pelvic region, as well as she had previously treated. This site was treated previously, but it recurs, and sacrum also previously treated with recurred. And this lumbar lesion also treated previously, and this dorsal lesion treated previously, which failures in the above and lower. So I have some question and discussion. What is the importance to do the test for the immunohistochemistry repeat test actually? And what will be her next course of management in case of extensive bony irradiation and progressive disease in hepatic vessels without visceral crisis? Chemotherapy or palliative chemotherapy? What will be the future immunohistochemistry stress test testing for these patients? Thank you. Thank you for patient hearing.
Thank you, Dr. Arifur Rahman, for your interesting case. I'd like to request Professor Ben Sir for your valuable opinion regarding the case.
Well, thank you, Dr. Dustin. Thank you for inviting me. This is a challenging case. I had a couple questions. Did you already mention that she had germline testing for BRCA1 or BRCA2?
No, she didn't.
All right, so there's a couple of options, I think. If it's available, germline testing for BRCA and BRCA1 or BRCA2. And again, if it's available, PARP inhibitors would be something to use if she was found to have a germline mutation. I don't know if that's available to you. Olaparib, you're probably familiar with some of the studies that have completed both in the metastatic and adjuvant setting with PARP inhibitors for breast cancer. So if she actually did have a pathogenic mutation in either BRCA1, BRCA2, maybe even PALP-B2, which is something that's data will be coming shortly, but that's also something that would be a great option for her. If she is BRCA1 or BRCA2, but you don't have access to PARP inhibitors, platinum-based chemotherapy might be an option. Most of us feel that platinums on BRCA1, BRCA2 related cancers operate by a very similar mechanism, but obviously have many untoward side effects, toxicity from off-target effects. The second thing, I don't know if you have available everolimus. I noticed that she had exemestane, but here we probably would have given her both as a combination therapy based off the Bolero 2 trial. And I think that that's something where, getting to your first question, we always try to reassess the receptor status if we ever get a new biopsy, because in this case, I don't know if it was a misdiagnosis by pathology or it was true heterogeneity on various parts of the tumor section. Both can occur, obviously, and I think knowing what one is dealing with in terms of receptor status can make an impact, particularly because sometimes we don't see this that often, but sometimes we do see HER2 negative become HER2 positive with clonal evolution and mixed heterogeneity. So that would also open up a lot more therapeutic options for her should she actually be now HER2 positive. So I do think if there's tissue available to get a repeat biopsy, as long as it's safe to do. Bone biopsies, as I think most people know, are a little bit challenging, and the receptors tend not to be of highest quality on bone biopsies due to the demineralization process of the pathology specimen. And then the other things that I was also going to talk about, again, I don't know if this is available to you, but if there is a next-gen sequencing option available on a metastatic or even the primary site, if she has a PIK3CA mutation, then in this country, at least, we do have the option of using alpelisib or Piqray. with endocrine therapy, and that might be something that could afford her benefit. I will be honest with you, my experience with that drug is that it can be fairly toxic. Hyperglycemia can be rate limiting. And so that's not something that I think would be an absolute necessary thing to try to get if you cannot get the testing or the drug. Lastly, and again, I don't know where this goes. Nobody does in terms of the lines of therapy, but one of the things that we have had success with here in this country has also been using a different CDK4/6 inhibitor after progression on another one. And probably the best examples now that we have that have been reported, not in a randomized perspective fashion, but retrospectively, is abemaciclib after progression on palbociclib with endocrine therapy. And so I personally have done that several times, and most of the time it works. You'll at least see some response. And I even had a patient that had a complete response. So I do think that that's another option for you if you don't want to use chemotherapy right away. Otherwise, I think Xeloda, oral 5-FU capecitabine is always a relatively reasonable, effective, and not as toxic choice for chemotherapy options in this patient population.
Thank you, sir. And regarding your lot of solution, one is NGS is available, but it is a little bit costly, as well as the rebiopsy from the liver lesion. It could be tried, and germline BRCA1/2 receptor testing we can do from here. But regarding if it is BRCA positive, should we go for the laparib, or it's also available in Bangladesh, local generic. So it's a good chance. Thank you for your opinion.
Thank you.
So, Dr. Rajesh Balakrishnan, sir, put some light on the case.
Thank you for inviting me, Arnangshu, Shajal, and the team from Bangladesh. This patient, as you see from the history, it's from 2016. So initially, he had a doubtful liver lesion, which was FNAC negative, but it could be liver mets also, we're not sure. And another thing was like the ERPR receptor status was triple negative status in the first time. And in the same slides and blocks, when it was submitted, it was ERPR positive and HER2 negative. As Dr. Ben had suggested, it would be better like if you could get some tissue now to repeat the ERPR and HER2 status and check what is the current disease status. And like the question for radiation is like, I saw that you have been planning for starting radiation to pelvis, cervical spine, and sternum. We need to keep in mind that she's already received radiation to the chest wall 50 gray earlier. Maybe you have to check whether the areas what you're treating has been already irradiated or not. That is one thing. And another thing, she has had multiple lines of chemo, so and multiple locations of vertebral body has been treated with radiation. Maybe the bone marrow suppression could happen, and she would not be fit for further chemotherapy. That also had to keep in back of her mind. I was thinking like my treatment choices was, what I was thinking was like, because she's never been given capecitabine, so that will be one good choice which you could explore. And another thing is to add denosumab. Denosumab as a thing for bones to keep it under control. It's a good choice. And as Dr. Bennett suggested, better to do for a BRCA genetic testing or a NGS and to find any targetable mutations are present or not.
Thank you, sir. This is also a concern for me that with a large area of irradiation with the spine, it is very difficult for her to withstand further chemotherapy. As the secondary meds when appeared, she started taking it and it was not well tolerable for her.
Thank you, Rajesh sir. I'd like to request Professor Khodeza Nahar madam for your valuable comment on pathological perspective on this case. Khodeza madam.
Thank you, Dr. Arnangshu. Thank you for inviting me for this case study. So what I can see, this case is a complicated and very challenging case. And as at this point, ERPR HER2 status shows ERPR positive and HER2 negative on the same biopsy tissue that was showing triple negative beforehand. I think it is, if Dr. Shajal clarifies, is it the same biopsy tissue that was reviewed? Then
biopsy tissue, they bring it, collect it from the Bangladeshi center, and they
okay. Okay, and now that there could be some tumor heterogeneity, so I think a newer biopsy will be valuable for determining the present status of ER-pair and HER2/neu. And as this case is a HER2/neu negative, there is chance that there will be PIK3CA mutation, which can be picked up by Foundation 1 CGX study, which could be of help for this particular patient for future management.
One question in this regards, what is, should we routinely go for the immunohistochemistry, repeat immunohistochemistry if we have that photograph with the attached? What do you think about this?
Yes, yes, as that depends upon your findings. If you find it frequently, then there is some discrepancy between the ER-pair HER2 of the same biopsies. Then there are many other issues, like technical issues and all these things. So in those cases, or if it depends on your input, that what is the present situation, how often it is happening. In that case, I think it's better to do to repeat the test from the center.
Thank you, madam. Now I would like to request Dr. Kazi Manzur Kader sir for your valuable comment.
Thank you so much, Dr. Onangshu and Dr. Arifur Rahman Shajal, for inviting me here as a panelist. So, in this clinical situation, what our foreign expert and our pathology madam said, my suggestion is here also to do BRCA1 and BRCA2 and PIK3CA mutation test. If these are showing positive, then we can go as per our guideline. Or if it is not possible, then we can give palliative chemotherapy. This is my suggestion.
Thank you, sir. Now I'd like to request Dr. Salim Reza sir for your valuable comment.
Thanks, Dr. Onangshu and Dr. Arifur Shajal for his case presentation. So this is a heavily pretreated cases. Basically, the treatment started on the basis of ER-PR HER2 negative, triple negative breast cancers. Then scenario changed. Then ER-PR positive, HER2 negative. So in this situation, my suggestion, actually with our previous panel members, we should do the re-biopsy for immunohistochemistry. If there is any HER2 positivity, then definitely there are so many options for HER2 breast cancer patient management. And we can do also the BRCA1, BRCA2 test. If it is positive, then we will start the patient with the olaparib. And in these heavily pretreated patients, as the patient did not receive cafezitamine, so we can also start the cafezitamine as a chemotherapy. Another way, we can also apply the radiotherapy on the metastasis side. So before giving the radiotherapy in the sternum on this area, we should think regarding the previous radiotherapy field. So this is my suggestions. Thank you.